Hi, everyone. Thank you for taking the time today to understand our presentation on nasal polyps and chronic rhinosinusitis. My name is Dr. Tom Casale, and I'm professor of medicine at the University of South Florida. So I'll say from the onset that I am not an ENT surgeon, so my opinion might be a little bit different than someone who performs surgery, but I'll try and be objective about the data that's been generated on how best to manage these patients. Before I start, I just want to inform you that I have some disclosures. That is, I receive consulting fees from many of the companies that make biologics for nasal polyps and for asthma. So what do we want to accomplish today? What we want to do is to talk about the phenotypes and endotypes of chronic rhinosinusitis with and without nasal polyps, based on what's understood so far about the immunologic pathophysiology and its impact on disease burden. And as we talk about this, I'll go into a little bit of an explanation about the differences between phenotypes and endotypes, because sometimes that's a little confusing. We'll also summarize mechanisms of action of these new and emerging targeted therapies, especially those biologics that are very specific for an individual molecule or pathway, and discuss the types of shared decision-making that you should be thinking about with your patient when you determine whether a patient who has not responded to traditional medical therapy might have to go an extra step. That is either functional endoscopic sinus surgery or a biologic. So let's, before we do that, we want to take a couple of questions, and this is a pre-polling test. So if you could answer the first one: the primary cytokines involved in type 2 inflammation, most common endotype in patients with chronic rhinosinusitis with nasal polyps are. I will give you a few more seconds to enter in your answers. All right, so it looks like most people feel it's IL-4, 13, and IL-5, and that is an answer that is correct, and we'll go through why that's correct later on. So if we give the second question, which biologic showed improvement in nasal polyp score by greater than 2 points in close to half the patient population at both weeks 24 and 52? So just to remind you that right now we have 3 biologics currently approved for the treatment of nasal polyps, and those are DUPILUMAB, mepolizumab, and OMALIZUMAB. Benralizumab is finishing up their phase 3 trials now. Okay, and next, which is the most commonly observed treatment-emergent adverse event across the clinical trials of all patients? So it looks like most people are saying injection site reactions. And of course, we'll go on for the next question. So this is a case: Mr. Brown, a 42-year-old male patient with severe chronic rhinosinusitis with nasal polyps, returns 12 months after endoscopic surgery complaining of persistent symptoms. You suspect nasal polyps have regrown, as type 2 inflammation is a predictor of polyp return. Disease scoring systems show some improvement, but don't meet EUFOREA criteria for adequate response. What does EUFOREA recommend now? So, return to medical management, short course of oral corticosteroids, biologic, exhalation delivery system with FLUTICASONE, or corticosteroid-eluting implantable stent. So it looks like we have a little bit more split on the various options. So feeling discouraged, he says if the nasal polyps are just going to grow back anywhere, why doesn't he go through all the expense, pain, and downtime of undergoing surgery again? Shared decision-making means the best action now would be to advise him to reconsider surgery, appraise him what the guidelines recommend, get him information about available biologics, and letting him know all his therapeutic options and pros and cons of each. Okay, so let's go back to our slide presentations, and we'll start off with a case. So we'll talk about Bob, who's a 45-year-old man with chronic rhinosinusitis with nasal polyps. He has asthma as a comorbidity, which we know is much more common. He complains the polyps have gotten worse over the past 2 years and require multiple oral corticosteroid bursts. He's compliant with saline irrigation and intranasal corticosteroids, but he complains that his sleep quality, work productivity, and social life are negatively affected. He's never had surgery. So what additional information would you consider most important at this point? So would you get a blood eosinophil count and serum IgE, CT scan, nasal endoscopy, spirometry, pheno? Well, when you think about this, what would be your thought process as to how you might treat this patient next? You might get a blood eosinophil count if you think that that will help you characterize the patient and allow you to make a more rational approach towards picking a biologic. Serum IgE by itself doesn't really help. However, some people do look at Staph aureus enterotoxin-induced IgE, which we'll cover later. Clearly, it would be important to get a good look, and that could be done with CT scan of the sinuses and or nasal endoscopy. Spirometry should be done just because he does have asthma and nasal polyps, and these patients tend to be worse. So the reason I would do it is that if he had really bad asthma as well as the nasal polyps, that might influence your decision, as you might want to do a biologic instead of endoscopic sinus surgery. Or exhaled nitric oxide. Exhaled nitric oxide in this patient probably wouldn't be extremely helpful at this point. It's a good marker for certain types of patients with asthma, but really hasn't been shown to be very good for classifying and characterizing patients with nasal polyps. So let's make sure we're all on the same wavelength, and I'll just give an overview of the disease. So remarkably, in the United States, there's about 29 million American adults diagnosed with chronic rhinosinusitis. That represents 11.6% of the general population. 20% with nasal polyps are 20% of these patients have nasal polyps and about 80% don't. If you have nasal polyps, you're more likely to be male. If you're not, you're more likely to be female. And of course, the combination is going to be harder to treat. We don't know why, but the United States appears to have the highest prevalence in the world of chronic rhinosinusitis with nasal polyps. As we talked about, almost 12% of the US population, whereas Canada, just up to the north, it's only 4.6%. China has a pretty high incidence, but they tend to have a different phenotypic presentation that we'll discuss a little bit later. And you can see Europe is very similar to the US. Now, we know that if you have nasal polyps with rhinosinusitis, your medical costs are going to be higher. That's clearly been shown in a number of studies, and here is one of them where you could see that in an observational study of 21,000 patients in a large claims database, almost 11,000 with chronic rhinosinusitis with nasal polyps were matched with the same number of patients without. And overall, it shows that if you had nasal polyps, you incurred about $11,500 more in annual medical costs than the controls. That's a lot of money. And that's made up of increasing use of medications, increasing hospital visits, office visits, medical care in general. So it all adds up in these patients that have this disorder associated with nasal polyps. Now, what are the diagnostic criteria and the common comorbidities of this disorder? Well, the diagnostic criteria include the following as shown on this slide. You have to have at least 2 of the following symptoms for at least 12 weeks: eucopurulent draining, nasal congestion, facial pain, pressure or fullness, and decreased sense of smell, plus at least one objective criteria, which would include either a positive endoscopic or sinus CT scan to document drainage, inflammation, nasal polyps, etc. So that's how the diagnosis is made. Again, more than 12 weeks of symptoms. Now, if you look at the anatomy and some of the characteristics, if you have nasal polyps, you could see that illustrated on the right-hand side of the slide. That's associated with severe obstruction of all the sinuses. And as a result of that, patients often complain of significant nasal obstruction, congestion. They have postnasal drainage, often with secretions. Loss of smell is common. They may have facial pain or pressure, but interestingly, that last symptom tends to be a little bit more common in patients with chronic rhinosinusitis without nasal polyps. They too have the other symptoms, but again, the 2 symptoms that tend to separate would be loss of smell with nasal polyps, facial pain and pressure without nasal polyps. But they're not absolutes. As you can see, there's overlap. And certainly now, in the middle of the COVID pandemic, we know that that's one of the things we look for, right, is patients that have a loss of smell. So you have to think about the fact that this can be due to a number of different causes. Defining uncontrolled and severe chronic rhinosinusitis with nasal polyps is important because that really dictates what your therapeutic options are going to be. Uncontrolled means that you have persistent or recurring symptoms despite long-term intranasal corticosteroids and having received at least 1 course of oral corticosteroids in the preceding 2 years and or previous sinus surgery. So you could see on this slide the definitions of each of those, but what about the patients with even more severe chronic rhinosinusitis. These are patients that have a nasal polyp score of at least 4, and that's 4 on a scale of 8, persistent symptoms despite long-term intranasal corticosteroids with the need for add-on treatment. And again, these patients often have a loss of smell, significant congestion, a decreased quality of life, and impairment as manifested by an elevated SNOT-22 score and an increase in symptoms as illustrated by a visual activity score. Now, importantly, if you have patients with chronic rhinosinusitis with nasal polyps, they tend to track with other diseases. So the 3 diseases that often occur with these patients include aspirin sensitivity, asthma, and allergic rhinitis. And you could see the increased odds ratio for each of those, with aspirin sensitivity being extremely more common. So that if you have a patient that develops aspirin sensitivity manifested by respiratory symptoms, it's extremely important that you get a good examination of their sinuses and nasal cavity to make sure that they do or don't have nasal polyps. We know that asthma is associated with this disorder, and asthma is worse in patients with polyps, and in patients with polyps, they tend to have a more significant disease when it's tracking with severe asthma. Now, if you look at the overall association between nasal polyps and asthma characteristics, you can see a couple of things. First off, if they have nasal polyps, they tend to be a little bit older. You can see their lung functions are not as good. They tend to have an eosinophilic picture manifested by either an increase of sputum or serum eosinophils or both. They tend to require higher doses of inhaled corticosteroid, but have worse control of their asthma and require more corticosteroid bursts with increased exacerbations. Now, the so-called Samter's triad, originally described by Max Samter many years ago, included 3 things, and that is aspirin sensitivity, aspirin, and nasal polyps. These patients tend to have asthma that's more severe than average and more difficult to control, with increased risk of death, usually from an overwhelming upper and lower respiratory exacerbation of their diseases when they're exposed to a non-steroidal. And they often present with overwhelming mucus production in the upper airways as the first symptoms, but then develop severe bronchoconstriction and wheezing. Furthermore, they have hyperplastic pansinusitis, recurrent eosinophil-rich nasal polyps, and again, significant mucus production and loss of smell. And this occurs with almost every COX-1 inhibitor. Most people, however, can tolerate meloxicam or those other COX-2 inhibitors. Now, I want to describe a little bit about the inflammatory endotypes and phenotypes. So, sometimes, again, this is confusing. So if you look at the effector cells and the primary cytokines and clinical features, there are differences in these 3 broadly based phenotypes of chronic rhinosinusitis. These are phenotypes. So in type 1, we know that cells that tend to generate interferon gamma and interleukin-12 are the primary players. And these patients tend to present more with purulent nasal discharge, and it tends to occur more in females than males. Type 2 is a typical type 2 mediated disease like we would see with allergic asthma or eosinophilic asthma. So the eosinophil, basophil, and mast cell play an important role, often driven by Th2 cells that secrete cytokines, important for the differentiation of these other cells and the production of IgE. And those cytokines are ILs 4, 5, and 13. And then the type 3 are those that are associated more with a neutrophilic inflammation. And these patients, therefore, would have involvement of Th17 cells, which produce IL-17, IL-22, and eventually neutrophilic chemotactic factors like interleukin-8. So these are three phenotypic characteristics of this disorder. They're not endotype. Endotype means that we can actually pinpoint the molecule or the pathway that leads to the disease. So if we take type 2, for example, if we knew that in an individual patient, IL-5 was the mediator that caused that patient's disease, that would be an endotype. So again, looking at the two main phenotypes, Th1, Th2, you could see there's a little bit difference in that the Th2 patients tend to have a higher incidence of comorbid asthma and allergic rhinitis, and also aspirin sensitivity. Now, looking at the Th2 phenotype in a little bit more in depth, you could see that there are certain mediators, cells, and cytokines clearly important. There are a number of things that can affect the nasal epithelium or the lower airway epithelium, which can activate those cells to produce other mediators that are important. So allergens, viral particles, cigarette smoke, etc., can stimulate the nasal epithelium to produce what we call alarmins. The three most common ones that we typically talk about are TSLP, IL-25, and IL-33. They're important because then they convert an undifferentiated T helper cell to Th2 cells and innate lymphoid cells to ILC2 cells. And those cells then secrete important cytokines that propagate this inflammatory pathways. So IL-4 and IL-13 cause B cells to switch from making IgM to IgE, and eventually that IL-4 mans a basophil or mast cell so that if you inhale an allergen, for example, you cause mediated release. They produce IL-5. And IL-5 is important for the differentiation and survival of eosinophils and also the chemoattractant for that particular cell to get into the tissues. IL-13, not really a potent chemoattractant, but it can induce mucus production, collagen formation, fibrosis, and in the lower airways is important for the development of airway hyperresponsiveness. So let's go back to Bob. So again, 45, nasal polyps, asthma, FEV1, below normal, 68%. He's got good reversibility. His FeNO is 35. That's elevated. Anything over 20, we tend to consider as being high. And he has a normal response to aspirin and nonsteroidals. He's already had 2 oral courses within the last 2 years of prednisone. He's on high-dose ICS and LABA, and he's using nasal saline irrigation with intranasal corticosteroids. So looking at this, the question you would ask, what would you do next? Okay, first thing you always ask, well, gee, is Bob taking his meds? How do you assess that? Well, besides actually getting the pharmacy records, we do look at FeNO. Now, if a patient is steroid naive and they have type 2 inflammation and they start taking an inhaled corticosteroid, that FeNO tends to drop pretty dramatically, as does the blood and airway eosinophils. So this patient has an elevated FeNO and he's got a lot of reversibility. So you could question whether or not, is he really taking his high-dose inhaled corticosteroids and LABA? If he was, maybe he wouldn't be as reversible. Maybe his FeNO wouldn't be as high. But we see this. We see this in adherent patients as well as patients that are non-adherent. It's just a red flag to make sure that you check on medical adherence. So the question is, what do you do next? And there are several options. You could send him to surgery. You could do a biologic treatment. And the advantage of a biologic would be if he's got uncontrolled severe asthma of a type 2 phenotype, then you might be able to pick a biologic that would treat both the polyps and the asthma. Or you could say, you know, the first two options are very expensive. Maybe we'll try something like EDS FLUTICASONE, or we could try alternate day oral corticosteroids. The last option is one that I don't typically use just because you're really relegating these patients to long-term corticosteroids, which can be associated with a lot of adverse consequences. But we'll go through each of these choices. So, medical management, saline irrigation. Some benefit has been reported, especially with large volume irrigation. No benefit from just spraying a little nasal saline in your nose. Intranasal corticosteroids are good, but in patients with nasal polyps, they help some, but they may not in any way cause those polyps to shrink to the point where the patient is asymptomatic. Oral corticosteroids we know help, but again, associated with a lot of adverse consequences. So what else can you do? Well, you could use an exhalation delivery system with fluticasone. This is the EDS flu that was on the other slide. This is approved as of 2017. And basically what it does is that the patients have a much greater intake of the corticosteroid into the target area that you want. And in their phase 3 trials, they showed that polyps were eliminated in 25% on at least one side by week 24 versus 8.7%. SNOT-22 scores significantly improved, and the need for surgery decreased by almost 2/3. So in my opinion, I would try this first before I would even consider additional surgery or a biologic. Why? Because in some patients it works very well, and although it's more expensive than regular intranasal corticosteroids, it's a pretty benign treatment and way less expensive than a biologic or endoscopic surgery. Speaking of surgery, the good side of surgery is that you get rapid relief of symptoms with about an 80 to 90% success rate. And this is an outpatient procedure that tends not to have a lot of complications. However, if we knew it was curative, there'd be no question I think everybody would recommend it. But the problem is that about 40% of patients have regrowth in about 18 months. And they have to continue the intranasal corticosteroids to prevent this regrowth. It turns out that eosinophilic or type 2 inflammation is a strong predictor of who is going to have a recurrence. So if you have those things in place, so you've already treated somebody with nasal irrigation, intranasal corticosteroids, short-term oral corticosteroids, then you have to ask yourself, what else can you do? And assuming that you've tried the FLUTICASONE preparation that's in the exhaled delivery device, you might also consider surgery. And again, you could see that although successful, quite a few patients require repeat surgery over the years. And that's one of the drawbacks, that it's not curative, but it does relieve symptoms fairly quickly. So another thing you could do is think about, gee, I could do an eluting stent, a steroid-eluting stent. Now, again, I'm not an ENT surgeon, so I don't do this, but this is especially useful in patients that have already had endoscopic sinus surgery. Then you put in the implantable stent, and that's has mometasone, which is delivered directly to the ethmoid sinus, typically over 90 days. These things tend to dissolve on their own. They don't necessarily have to be removed at all. And it's shown that you have a significant reduction in nasal obstruction and congestion, and a very good 61% reduction in the need for revision surgery. So this would also be an option for consideration. Now, we've been mentioning biologics. Who are the best candidates for biologics? So the criteria used for considering a biologic include the following: presence of bilateral nasal polyps, history of surgery. If they have, then you need 3 of the criteria listed below. If they haven't, then you need 4 of the criteria listed below. And that is, number 1, evidence of type 2 inflammation, because again, all these biologics are targeted for type 2 inflammation. The need for systemic corticosteroids, specifically 2 or more courses in the past year, impaired quality of life, smell, and the diagnosis of comorbid asthma. If you meet those criteria, then you have choices of biologics. So the first 3, DUPILUMAB, OMALIZUMAB, mepolizumab, and I'll show you a little bit of the data in a second, are all approved for the treatment of chronic rhinosinusitis with nasal polyps. DUPILUMAB blocks the IL-4 alpha receptor, and as such, blocks the effects of both IL-4 and IL-13. Omalizumab, of course, has been around for a long time, and it blocks IgE. And mepolizumab is the most recently improved, but it's been around also for a long time for the treatment of asthma, as it is a monoclonal antibody against IL-5. Benralizumab is not yet approved. They are in the middle of their phase 3 trials. We haven't seen the results, but it works slightly different than mepolizumab in that it binds to the IL-5R alpha, that is the receptor of IL-5. As such, when it binds, it causes antibody-dependent cell-mediated cytotoxicity of the cells that have that receptor. And those cells include both eosinophils and basophils. So in fact, you wind up getting less eosinophils in the tissue itself, due to cell-mediated death from the use of benralizumab. Now, important to either decide when to use it or whether or not a patient responds is a nasal polyp scoring system. And that's shown on this slide, where you could see that it goes from a scale of 0 to 4, where 4 is very large polyps and 0 is none. And we'll talk about this in a second, but if you put somebody on a biologic, then how do you assess whether or not they're a good responder or not? The important thing to look at is how much did they decrease their nasal polyp score. Furthermore, there's a subjective severity scoring system, and that includes rating of symptoms on a scale of 0 to 3, 0 being none, and 1 being mild, 2 moderate, 3 severe. And of course, it focuses on congestion and obstruction, which is the most significant symptom for these patients. Here's some of the results. So these are the phase 3 data results published for DUPILUMAB, so-called Liberty studies. 2 different studies. One on the left-hand side, and you could see that patients received DUPILUMAB every 2 weeks for 24 weeks, and then it was stopped. The second study, SINUS 52, patients received DUPILUMAB for 52 weeks, but there were several arms to this study. So there is a placebo arm shown in gray, but in the active treatment group at the end of 24 weeks, the primary endpoint, patients were randomized to either continuing every 2-week treatment or spacing it out to every 4 weeks. And I think what you could appreciate from this is that when you look at the polyp score and the nasal congestion obstruction score, you get a pretty marked improvement that occurs very rapidly. And in the nasal polyp score, you decrease that score by 2, which is clinically meaningful as well as statistically significant. And the same with the congestion, a very significant and clinically meaningful decrease. Interestingly, though, you could also see that when the DUPILUMAB was stopped at 24 weeks, patients tended to go back. We don't have as much long-term data with the biologics, but if it's like asthma, it's possible that these drugs have to be continued indefinitely. We don't have any good way to say, look, this patient is going to have a long-standing remission or not require therapy. Nonetheless, pretty remarkable results, and that translated into something even perhaps more important. Here we have the percentage of patients in the pooled analysis of both studies who received either oral corticosteroids or underwent surgery during the trial period because they were treatment failures. And you could see a strong reduction in the need for surgery or oral corticosteroid burst. So 2 things that drive up healthcare costs and are associated with adverse events. Safety-wise, basically pretty much the same as what you see with patients that are treated for asthma. Now, if you remember that one question, the most common adverse event, actually it was nasopharyngitis and not injection site reactions, which I thought was a good guess as well. But you could see that the event profile between placebo and active drug is pretty similar. How about OMALIZUMAB? It's a 24-week study, and again, In this case, omalizumab is dosed based on body weight. So what you're seeing in POLYP 1 and POLYP 2, at the end of 24 weeks, the primary efficacy endpoint, that is nasal polyp score, was decreased by about 1. So not quite as much as what we saw in DUPILUMAB, but still a clinically meaningful reduction. Furthermore, if you look at the nasal congestion score, again, clinically meaningful and statistically significant improvement in active treatment versus placebo. Safety profile, no different than what we typically see in asthma, and remarkably similar to what you saw in the placebo. Mepolizumab. So this was just published this year in April, and they have their study is called SYNAPSE. It was published in Lancet Respiratory Medicine, and you could see that the patients that had a 1 point, 2 point, 3 point, 4 point, or 5 point improvement in their nasal polyp scoring was higher in the active versus the placebo group. Furthermore, in regards to their VAS symptom scores, again, higher in the active versus the placebo group. They too showed a benefit in reducing the need for surgery, albeit not quite as much as what we saw with DUPILUMAB. And interestingly, if you look at the data for mepolizumab, which has not been shown with either of the other two biologics, you actually have a little bit better response in patients with higher blood eosinophils. Adverse event, pretty much the same again between active and placebo, and no different than what we typically see for asthma. So all three drugs have efficacy. All three drugs appear to be fairly safe. So choosing a biologic and shared decision-making. So the first thing you would do is confirm the diagnosis of uncontrolled severe rhinosinusitis with nasal polyps. Check for comorbidities, because again, that may lead you towards using a biologic. Make sure that type 2 inflammation is highly likely either by elevated blood or nasal eosinophils. Inform the patient on treatment options, which would include a biologic, perhaps another endoscopic sinus surgery, or if you haven't tried it yet, the exhalation delivery system with FLUTICASONE. And then you discuss that with the patient, shared decision-making. And also, you as a clinician will have to make that decision as to which of the three biologics you're going to pick. We don't have head-to-head studies of these three biologics. There will be some head-to-head studies coming out in the near future, but right now it's going to be a judgment call. If you have a patient, for example, that has a lot of Staph aureus enterotoxin produced in their upper airway, that can serve as a significant stimulus for the production of IgE. So a drug like omalizumab might be better. If you look at across the board, the results from the different pivotal studies, the ability to reduce polyp size appears to be better with DUPILUMAB. And certainly if you had someone with a comorbid condition besides asthma, like atopic dermatitis, you might pick that. You might pick mepolizumab if you're comfortable with treating patients with this drug. It's a standard dose every 4 weeks. And of course, the biggest influence will likely be what the insurance company is going to pay for. How do you know whether a patient's a responder or not? Well, after about 6 months, you have to determine whether the patient has improved in their smell score, their nasal congestion score, nasal polyp score by at least 1, SNOT 22 by about 9. So all of those things that we looked at in the pivotal data on the previous slides. If they don't, then the suggestion is either you change to surgery or you might try another biologic. If there's a partial response and the improvement is acceptable to the patient, probably continue. If the improvement, even if it meets those criteria, but the patient is not satisfied, well, you might consider surgery under a biologic or add a short course of systemic oral corticosteroids. After 12 months, you look again to see whether or not these criteria are improved. And again, all of these definitions should be fulfilled. If they're not, then either talk to the patient and consider if they're satisfied, maybe just continue with the biologic. If they're not, then consider switching or surgery. Here's an algorithm that we published earlier this year on who to consider for a biologic. So the first thing you do, of course, you establish a diagnosis. And if you look at the left-hand side, if the patient is a surgical candidate, you ask that first. And if the answer is no, then consider a biologic. If the answer is yes, and they have asthma comorbidities, you talk to the patient and you would perhaps consider a biologic agent. Otherwise, do surgery. If they're not controlled, consider a biologic agent. If they are controlled, then that's a good sign. And you might use one of the steroid-impregnated stents or intranasal corticosteroids to maintain control. These shared decision-making should occur after failure in standard of care with intranasal corticosteroids, irrigation, and intermittent oral corticosteroids, after failure of a first surgical procedure with or without a corticosteroid stent, after failure of second or more surgical procedures, and after failure in standard of care in a patient that has concomitant type 2 asthma and or type 2 comorbidities, for example, atopic dermatitis. Well, we're not there, but we do have much better options than we did many years ago. But what we need are better biomarkers. We need better biomarkers to predict who is the best candidate for a biologic and which biologic. But we also even need better biomarkers to predict who might be a better candidate for surgery. For the patients that have similar characteristics, it's great that we can conceive of having comparative studies between the biologics, direct head-to-head studies. We also have to explore cost because these biologics are very expensive and there's no evidence that they cure disease. So if the patient requires a biologic long-term, that could be a substantial healthcare cost. Similarly, surgery is expensive, and if you have to repeat it every couple of years, that adds up to a lot of cost as well. The importance of comorbid conditions. If the patient has severe asthma and you're able to improve both disorders, then you might be more likely to use a biologic, and we need more information on that, and we certainly need long-term studies to determine if you could treat patients for a finite period of time with a biologic and stop. We know that that really hasn't been the case with asthma, but maybe the upper airway is different, and that is a possibility. And a better algorithmic approach for treatment failures, especially with biomarkers. Information patients need for shared decision-making? Well, they need to know how a drug is used, what are the pros, what are the cons, and what are the costs. And we've talked a little bit about this. The intranasal corticosteroids, yes, they work along with nasal steroids. They're both inexpensive, they're both benign, but they don't have as big of a impact in controlling nasal polyp growth or recurrence after surgery. The exhalation delivery systems do better at that, but they're not cheap, and the cost can be fairly expensive. And again, you're probably talking about something that has to be delivered forevermore. Surgery, that's going to be surgical, you got a one-time cost, but you may have to repeat that. And the corticosteroid-eluting stents, at least that can be done as an outpatient, but again, expensive, works better after following surgery. And then, of course, biologics, which we discussed. So back to Bob, uncontrolled severe disease with asthma comorbidity. This is when we would make the decision with the patient, giving them the pros and cons, and saying, look, do you want surgery? Well, they may not want to undergo surgery. They're worried about time they miss from work and potential adverse consequences. We have 3 biologics we could offer them. But again, are they the right candidate? Do they have the type 2 biomarkers that would signify a better response? And will their insurance cover the biologic long-term? So something that clearly needs to be discussed with the patient. So in summary, this is a highly prevalent disease accounting for about 20% of all patients with just chronic rhinosinusitis. Common comorbidities include asthma, especially allergic rhinitis, and aspirin sensitivity. It's usually a type 2 inflammation with the key cytokines of IL-4, IL-5, and IL-13, although we're not yet sure of the potential role of those alarmins, which we think could be important. And it's very likely that you'll see clinical trials published in the near future looking at monoclonal antibodies that block the alarmins. They have been shown to be effective, at least blocking TSLP in patients with severe asthma. Medical management often shows short-term response and high failure. And of course, we know there's a big downside in treating patients with bursts of corticosteroids, even short bursts, and especially if they're older. Endoscopic sinus surgery can be successful, but you have that high rate of recurrence. So it's something to think about. And then, of course, the 3 biologics now approved, and it's likely that you will see more. Use that shared decision-making for personalized selection. And it really depends upon the patient's goals, dosing preference, insurance, and ability to pay. So now we're going to do some post-test polling. So primary cytokines involved in type 2 inflammation in patients with chronic rhinosinusitis with nasal polyps. All right, so the correct answer is IL-4, 5, and 13, and there's some other cytokines that are probably important in that. but remember the IL-17 is most associated with neutrophils. Which biologic showed improvement in nasal polyp scores by at least 2 in close to half the patients at weeks 24 and 52? And you're correct. DUPILUMAB is the right answer. OMALIZUMAB was about a little over 1.1. Mepolizumab was just shy of 1. Which is the most commonly observed treatment-emergent adverse event across the clinical trials? And we covered that. Now everybody's going to say nasopharyngitis. Initially, everybody thought it was injection site reactions. Okay, next. So, Mr. Brown, here he is again. He's got nasal polyps regrowing as type 2. Disease scoring systems show some improvement, but do not meet criteria for adequate response. What does EUFOREA recommend now? So we have a little bit of a split decision, and I think that reflects where we're at, right? I think in part, this is the type of thing that my personal preference would be to use an exhalation delivery system with FLUTICASONE if they haven't been on it. We don't know what dose of intranasal steroid the patient was treated with. If that patient did not respond, I might consider a biologic just because he also had uncontrolled type 2 mediated asthma. Okay. So feeling discouraged, he asks if the nasal polyps are just going to grow back anyway. He doesn't want to go through all the expense, pain, chill, downtime of having surgery. So what's the best action now? Well, if he doesn't want him to have surgery, what would you do? So just like everything else, walking him through all the different options, because there's no absolute right answer, and doing that shared decision making with the patient is the right way to go. All right, so we could open it up for any questions that people might have. So no questions at this time. So while you're thinking about potential questions, here we go. Now they're coming in. So what's the recommended oral steroid dosing? Good question. Nobody knows. Typically, we would use 1/2 to 1 milligram per kilogram for 5 to 10 days as a short burst of oral corticosteroid. But the optimal dose and duration is not known. That's difficult, but that's what would typically be used. Next question is, should clinicians be performing subjective tests like SNOT-22 and nasal congestion scores in their offices or clinics? I think so. If you're, it's like treating any other disease, and especially if you're deciding whether or not you want to use a biologic. Very expensive drugs. You have to prove to yourself and the patient that they're getting better. So it would be nice to have some sort of, quote, objective, subjective information. If you had a SNOT-22 score and along with the nasal congestion score prior to treatment, regardless of the treatment, and then look to see whether or not that improves, along with either endoscopy or CT showing decrease in nasal polyp size, I think that would make you a lot more comfortable as to whether the decision you made in regards to their treatment was the right one, or you need to consider something else. So the next question is a very practical one. So if you have a patient that is interested in biologic, but reluctant because of cost, what do you do? Well, I think that's when, your office team has to help you. There are some programs also from the pharmaceutical companies that can help get approval for these biologics. And I think because it is so expensive, you really need to make sure that they are responding to it. And try and, you may pick the one that perhaps has the best coverage for that individual. All right, well, I would like to thank everyone for joining us today. I hope you learned something. And there's some information that'll be coming up to claim your CME. So thank you and have a good rest of the day.